Rosacea. Definition. Rosacea is a chronic inflammatory disorder affecting the blood vessels and pilosebaceous units of the face. The etiology is not well understood. Clinically, papules and pustules are superimposed on the background of erythema and telangiectasia. Rosacea. A. Papules and pustules superimposed on the background of erythema in a typical, fair-skinned patient. B. Rosacea seen in a patient with a darker skin type. Incidence. Rosacea is a relatively common disorder that affects primarily middle-aged adults. The global prevalence of rosacea is approximately 5.5% of the adult population, based on a systematic review and meta-analysis of 32 studies examining over 26 million individuals. History. The disorder often has a gradual onset. Usually, the patient first notices erythema. With time, telangiectasia appears. The development of papules and pustules is usually sufficient for the patient to bring the problem to a physician's attention. Trigger factors, such as exercise and alcohol, can cause a flare of the redness. Most, but not all, patients have a fair complexion and light-colored irises. Rosacea can affect the eyes, known as ocular rosacea. Eye symptoms include redness, burning, itching, or a foreign body sensation. Always ask a patient with rosacea if they have eye symptoms. Physical examination. The four major clinical subtypes of rosacea are as follows: 1. Vascular, 2. Papulopustular, 3. Rhinophema, and 4. Ocular. Each type may occur independently, and there is no typical progression from one to the other. Usually a patient with rosacea presents with a combination of vascular, papulopustular, and ocular findings. Typically, papules and pustules are superimposed on a background of erythema and telangiectasia. Sometimes, only the erythema and telangiectasia are present. Characteristically, comedones are not found. The disease affects the central third of the face and spares the lateral aspects of the forehead and cheeks. Blepharitis and conjunctivitis are common. Bulbous thickening of the nose is rare and occurs most commonly in men. Rarely, inflammation from rosacea can lead to facial edema. Rosacea. Ocular sign, blepharitis and injected conjunctiva. Rosacea. Extreme phymatous change leading to bulbous thickening. Rosacea. Chronic inflammation causing periorbital edema. Note the papules on cheeks. Differential diagnosis. Rosacea is distinguished from acne vulgaris by the absence of comedones, the background of erythema and telangiectasia, the onset in middle life, and the distribution in the central third of the face. Rashes that may be confused with the vascular element in rosacea occur in lupus erythematosus, dermatomyositis, photodermatitis, and, most commonly, seborrheic dermatitis, but none of these exhibit pustules. Interestingly, seborrheic dermatitis is often seen in conjunction with rosacea. Seborrheic dermatitis affects the concave surfaces, nasolabial folds, whereas rosacea affects the convex surfaces. In patients with rosacea with a prominent flushing component, carcinoid syndrome sometimes enters the differential diagnosis. Epidermal growth factor inhibitors, used to treat a variety of malignancies, can lead to a facial acneiform eruption, which can be confused with rosacea. Seborrheic dermatitis. Scaly red, hypopigmented patches affecting nasolabial, convex surface, folds. Acneiform eruption from epidermal growth factor, papules and pustules on the face. Differential diagnosis of rosacea. Acne. Lupus, dermatomyositis. Seborrheic dermatitis. Carcinoid syndrome. Acneiform eruption from epidermal growth factor. Laboratory and biopsy. The diagnosis is almost always made clinically. A biopsy is rarely needed, but if performed, shows vascular dilation, often with degenerative changes in the collagen and elastic fibers in the upper dermis. The papules and pustules in rosacea are similar histologically to those found in acne vulgaris, but in rosacea, the inflammatory infiltrate is more likely to have a granulomatous component. This represents a foreign body reaction in the dermis to the extravasated contents of affected pilosebaceous units. The granulomatous response can be impressive and has been occasionally confused with granulomatous disorders, such as sarcoidosis and tuberculosis. Note, histologically, a granulomatous reaction is often present and may be confused with sarcoidosis or tuberculosis. Rosacea. Epidermis, intrafollicular inflammation. Granulomatous reaction to the contents of a ruptured pilosebaceous unit.
Therapy. Topical metronidazole 0.75% or topical azelaic acid 15% applied twice daily are both effective in treating the papules, pustules, and erythema of rosacea. The mechanisms of action are unknown. Systemic antibiotics are used frequently for the papular and pustular components and are especially beneficial in treating ocular rosacea. Do not forget to ask each patient with rosacea if they have eye symptoms. Sometimes, the erythema is also improved. Low-dose doxycycline, 20 mg twice daily. Exerts an anti-inflammatory effect and is the usual treatment. Most patients respond within 1 month, after which the drug can often be tapered, but some patients require long-term maintenance treatment. Systemic isotretinoin, usually in low doses, is reserved for the rare patient with severe disease that has resisted all other types of therapy, but it does not lead to a lasting response as seen in acne. Laser treatment, pulsed dye laser, is the only effective and definitive therapy for the erythema of rosacea, and treatment typically needs to be repeated every several years to maintain response. 2 topical, alpha-adrenergic receptor agonist therapies, brimonidine tartrate 0.33% gel and oxymetazoline 1% cream, are FDA approved to treat persistent facial erythema from rosacea. Topical steroids should not be used because they are well known to aggravate the disease. Sun exposure can also be an aggravating factor, and some protective measures should be recommended. Avoidance of triggers like alcohol prevents flushing. Note, strong topical steroids are contraindicated. Therapy for rosacea. Initial. Metronidazole gel or cream BID. Azelaic acid gel BID. Daily moisturizer containing sunscreen. Alternative. Doxycycline 20 mg BID for papulopustular and ocular rosacea. Isotretinoin. Pulsed dye laser, vascular rosacea. Or topical brimonidine 0.33% gel, oxymetazoline 1% cream for persistent facial erythema. Course and complications. The disease is usually chronic, but most patients respond well to therapy. In many patients, however, therapy must be continued for months to years. The erythematous component may be improved by therapy, but telangiectasia persists. Rhinophema sometimes develops in patients with rosacea. As the name suggests, this disease involves hyperplasia of the sebaceous glands, connective tissue, and vascular bed of the nose. The hyperplasia can be striking, resulting in a bulbous nose. Contrary to popular belief, rosacea is not a sign of excessive alcohol intake. Rhinophema requires referral for surgical treatment of anatomic resculpturing of the nose, example, dermabrasion, Shaw scalpel excision. Alternatively, lasers can be used for sculpting, example, ablative carbon dioxide. Ocular complications occur in some patients with rosacea. Eye findings range from blepharitis to conjunctivitis and even keratitis. The latter can be severe and has been known to result in visual impairment. Oral doxycycline is helpful for ocular complications. Pathogenesis. The pathogenetic mechanisms in this disease are not well understood. For the vascular component, investigators have suggested that sun exposure damages the collagen support of the vascular network, thereby resulting in vasodilation. Other aggravating factors that have been incriminated, but not well proven, include the ingestion of foods that cause vasodilation, example, hot liquids, alcohol, and spicy foods, and psychologic stress. Immune mechanisms have also been implicated, with immunoglobulin deposition occurring at the dermal-epidermal interface. The pathogenetic significance of this finding remains unclear. Clearly, genetics play a role as the family history of rosacea is often positive in a patient with rosacea.
Clinical case. A 42-year-old woman presents with a 3-year history of recurrent facial redness involving the cheeks, nose, chin, and forehead. She reports episodes of flushing triggered by hot beverages, spicy foods, alcohol, and sun exposure. Physical examination reveals persistent centrofacial erythema with multiple telangiectasias and several inflammatory papules and pustules. No comedones are present. She denies muscle weakness, photosensitivity, diarrhea, wheezing, or systemic symptoms. What is the most likely diagnosis? A. Acne vulgaris. B. Systemic lupus erythematosus/dermatomyositis. C. Seborrheic dermatitis. D. Carcinoid syndrome. E. Rosacea. Correct answer, E. Rosacea. Explanation. Rosacea is characterized by persistent centrofacial erythema, flushing, telangiectasias, and inflammatory papules/pustules without comedones. Common triggers include heat, sunlight, spicy foods, alcohol, and emotional stress. Acne vulgaris usually presents with comedones, open and closed, which are absent here. Systemic lupus erythematosus/dermatomyositis may cause facial erythema but typically has photosensitivity and/or systemic features such as muscle weakness in dermatomyositis. Seborrheic dermatitis presents with erythematous patches and greasy scales, especially in the nasolabial folds, eyebrows, and scalp. Carcinoid syndrome causes episodic flushing but is usually associated with diarrhea, wheezing, and other systemic manifestations.